Good morning, good afternoon, good evening to everyone, wherever you're joining. Welcome to today's EPI-WIN webinar, which is on the changing perspectives of Mpox. For those of you who are new to EPI-WIN, we use this platform, which is a WHO information network for epidemics, to make science accessible, understandable, and relevant for everyone, for public health emergencies, by bringing you the experts globally on issues of importance to all of us in public health emergencies now. For today's session is going to be moderated by Priya Umachandran. So over to Priya to moderate the session.
Thank you, Supriya. My name is Dr. Priya Umachandran, and I am a science translation consultant in the Science and Knowledge Translation team at WHO in the Health Emergencies program. A few points of housekeeping. This webinar is being recorded and streamed through YouTube and Zoom. Please do feel free to introduce yourself on the Zoom chat. There will be a Q&A after the panelists have spoken. So please do add any questions for the panelists to the Q&A box. That will enable us to see those questions and put them to the panel. This webinar will be available afterwards on the EPI-WIN homepage on the WHO website, and that link is being added to the chat as we speak. So without further ado, we'll carry on to the topic of today's webinar, which is changing perspectives on the Mpox outbreak. And specifically today, the webinar will be looking at different elements of the outbreak and what has changed and what we have learned so far during this outbreak. We have a really wonderful panel of experts with us today to discuss this topic. So I would like to invite Dr. Sylvie Briand, Director of Epidemic and Pandemic Preparedness and Prevention at WHO, to provide some welcome remarks. So Dr. Briand, you have the floor.
Thank you very much, Priya, and good morning, good afternoon, good evening. It's a real pleasure for me to be with you today. I really enjoy those Wednesday WHO webinars under the EPI-WIN platform and the dialogue we have on important subjects. Your questions and comments are really welcome, and it helps us a lot to understand what are your concerns and to provide you with the tailored information that best fits your needs. Today, we are going to talk about Mpox. It's not a new disease, and we have been monitoring it since many decades. But the recent outbreak is really a case study for emerging diseases. A few years ago, if someone would have asked me about the possibility of a monkeypox outbreak producing more than 85,000 cases in 110 countries and territories, I would have told this person that's impossible. But in 2022, we realized that it is possible for a virus previously confined in some endemic countries to travel around the world and infect thousands of people in all regions. The question we can ask ourselves is, how long does it take for a virus to escape its ecological niche? How long does it take for this virus that is only locally transmitting in settings where animal reservoir is to spread around the world? I don't have the answer, but if we look back at recent events like Zika, for instance, we see that it's a matter of years. So for Zika, we saw sporadic cases since the 60s, but since 2007, we started to see small outbreaks in Africa and Asia, and epidemics in the Pacific Island in 2011, 2012, and then a major epidemic in Brazil in 2016-17, spreading in more than 60 countries in a matter of months. So there is a slow start, but then when we have increasing outbreaks in different settings, then it's very likely to have a spread around the world. So for Zika, for instance, as of today, the virus has been reported in at least 89 countries. So we know that there are many viruses out there that are currently only circulating locally, and WHO is carefully monitoring them to detect as soon as possible when the risk of spread is increasing. And in this monitoring, we work very closely with our sister agencies, FAO and WOA, and also UNEP, to understand better the dynamic of those emerging viruses in the setting we know they are living. But this joint work with other UN agencies is critical to help countries to have early signals and also to get prepared to face epidemic of new diseases. So today you will hear our distinguished speakers explaining what has changed recently with Mpox, what are the challenges posed by this disease, and also what are the opportunities for us to be better prepared for future emergence. We were fortunate with Mpox to have vaccines and treatment. Those vaccines and treatment were developed for smallpox and can be used for Mpox. Smallpox has been eradicated in the 80s, but the global health community always wanted to make sure that we have the tools to combat smallpox in case it reemerged. So we didn't have smallpox, fortunately, but we have had monkeypox, Mpox, and so we have those tools, but we need to also make sure that they are equitably distributed. So Mpox offers us an opportunity to learn about emerging zoonotic diseases. And in particular, it gives us an opportunity to calibrate the response to the risk and develop a nuanced approach to these emerging diseases. Because when we have a new disease appearing, there is a lot of fear. And then after some time, if it's not as severe as expected, there is a lot of complacency. So it's important to react quickly to an emerging disease without being driven by fear. And we need to always be vigilant to emerging viruses and put in place the measures and tools we have to reduce transmission, reduce suffering, and reduce unnecessary mortality. So thank you again for joining this exciting journey in the world of emerging pathogens. And thanks to the speaker for sharing their knowledge and expertise and for their commitment to translate science for us. Over to you, Priya. Thank you.
Thank you so much, Dr. Briand, for that great overview of the outbreak and also drawing out those lessons we can really learn from Mpox to other emerging pathogens. So it's now my pleasure to invite Dr. Anna Hoxha, an epidemiologist with the WHO Health Emergencies Program, to discuss with us the changing epidemiology of Mpox. So Dr. Hoxha, you have the floor.
Thank you. Thank you, Priya. Can you please put the slides, or you want me to share? If I may start, so to introduce myself, I'm an epidemiologist. I have been working with the global surveillance of Mpox in the last almost a year, and I will be giving you a short presentation trying to show what we have learned from Mpox in this year, what was new, what did slightly adapt our knowledge of Mpox and its main characteristic previously and as of 22-23 outbreak. Can you please confirm you have the slide?
Dr. Hoxha, is it possible for you to share your screen with the slide? Apologies for this, but I think
yes,
it's a bit of a delay, so in the interest of time. Sorry about this.
It's okay, I can share my screen. Can you confirm you see my slides?
Yes, we can see them. Thank you.
Okay, thanks a lot. Yeah, as I mentioned, I will be shortly explaining the changing epidemiology of Mpox observed, and Rosamund will follow. She's the technical lead of Mpox after me. Okay. Looking at the main characteristics of Mpox, if we think about an outbreak in terms of time, person, place, the first thing that we see has changed in the epidemiology is the geographical spread of the infection. So if we see everything I will be presenting in the coming slides, there will be two parts of the slide. One that is referred to the period before the 2020-2023 outbreak, which refers mainly from the 70s up to 2021. And on the right side, you will have what we know from this current outbreak. Previously, we know that Mpox was spreading mainly in Central and West Africa. It's a zoonotic disease. In there, we had observed transmission from animals to humans, but as well human-to-human transmission. Additionally, we had some sporadic importations in the countries you see on the left slide highlighted in violet. So you can see globally the number of countries affected was quite limited. If we go on the right side of the slide, we see the countries affected in the current outbreak. We are more than 100 newly affected countries. So these countries had previously not reported Mpox cases. Most of the cases are focused in the regions of Europe and the Americas, so the darker blue countries, but we can also see spread in all other regions of the world. And we also see that spread continues also in West and Central Africa, also increased by the current outbreak. Continuing, if we look at the transmission dynamics, what we knew and what we know currently, we knew previously that the most affected groups by the infections were children and young adults, with a kind of gradual increase of age. There were some theories why these groups were the more affected, maybe the most exposed to animals, but as well, there was considered some protective effect from previous smallpox vaccination for the older population. What we saw in the current outbreak, that the most primarily affected group were adult men who have sex with men, as also abbreviated as MSM. Although there were other demographic groups, so we had children affected in this outbreak, we had women. Most of the bulk of the cases were among adult MSM. If we look at the epidemiology, previously we would observe sporadic cases and outbreaks, while now we had in the last almost a year a sustained community transmission in most countries. Now the epidemic has started to slow down, going down in many settings. Many countries are not experiencing sustained transmission anymore, but this is what was going on for almost a year. In the transmission, previously we had humans infected while they had a contact with an infected animal, and followed by short chains of human-to-human transmission. What we observed in the current outbreak is that the transmission was almost exclusively human-to-human, and there were large amplifying events, and the chains of transmission tend to be much bigger than what previously observed. In terms of dissemination, previously we had that the infected people were mainly related to hunting or household spread and travel, while now the spread was mainly due to sexual contact through MSM sexual networks. So somehow the whole dynamic of transmission, what we observed in this outbreak, was different than what was observed previously. Continuing with the differences, some differences were also observed in the clinical manifestation. Previously described cases, they tend to have an initial prodromal phase that presented temperature, headache, fatigue, lymphadenopathy, followed by lesions that were distributed in a centrifugal distribution and focusing primarily on face, trunk, arms, legs, palms, and soles. These lesions tend to have stages, and also they were also present in genitals and mucosas, but less often. What we observed in the 2022-2023 outbreak is that some cases, they seem to not present this prodromal phase with temperature, headache, and lymphadenopathy. They just showed lesions directly, or if they had the prodromal phase was very mild and was not noticed by the case. Some cases tend to have few lesions, and some of them presented even without lesions at all. Some cases had anorectal and mucosal lesions. So there was a larger presence of mucosal lesions than what was previously observed. There were more genital and anal lesions than what were previously observed. And some of the new clinical manifestation included parotitis, balanitis, urinary retentions, and proctitis. Some of the understanding is that the lesion manifestation might be due to this different route of transmission, which was through sexual contact. Continuing with the disease severity, previous studies that were mainly performed in Democratic Republic of the Congo, Nigeria, in Republic of the Congo, in Central African Republic, and some observation in the United States, so were very limited. They showed that the disease was more severe in children, pregnant women, and immunocompromised patients. Some of the complications include corneal ulceration, vision loss, bacterial infection, sepsis, encephalitis, depigmentation, and the case fatality rate varied. There was some difference between the different clades of Mpox, clade 1 and clade 2. We will go more in details into the clades later on, but somehow it ranged from 1 to up to 10% of the cases died. What was observed in this outbreak is that, and this information came mainly from countries in Europe and the Americas, cases overall presented with less severe illness. The majority of cases were okay just with the treatment of the symptoms, with pain relief medication. Most severe cases were again in children, but as well elderly and immunocompromised patients. There were complications such as meningoencephalitis, necrotizing lesions, and multi-organ involvement. Some of these were also due to the fact that some of these cases had co-infection, especially HIV. And the overall case fatality ratio in this outbreak was smaller, lower than what was observed previously. Globally, we are less than 0.1%, and in Africa, we are around 3%, but here there are also differences between the clades. As I mentioned previously, going a little bit more into the genomic spread, which also has impacted this outbreak, we know that overall Mpox, monkeypox virus, so the name has changed for the disease in Mpox, but the virus is still called Mpox, presents two clades, clade 1, which is mainly spreading in African countries, and it has been found in animals and in humans. While clade 2, which is ulteriorly divided in clade 2A and 2B, the 2A was observed in animals and humans, while the 2B is observed only in humans. This lineage 2B is the driver of the current outbreak. It was first identified in Nigeria in 2017. This is why we say that the current outbreak is somehow linked to the Nigerian outbreak of 2017. If we look here at the genomic trees, we have also, as previously, a tree for the cases observed previously to this outbreak, and you can see that there were cases from clade 1 and clade 2, but the clade 2 was mainly 2A and 2B sublineage A2. While in the 2022-2023, we see that almost all cases reported, this is data from open source databases, they are mostly from clade 2B, and especially from the sublineage B1. It's all the purple dots that you see in the genomic tree on the right. And if we look at the distribution of this clade in the current outbreak, you can see that it's the clade 2B, it's all over the place. It's in a lot of countries, everywhere. We can see that most of it is sublineage B1, which is the reddish and the greenish of these small pie charts. Hopefully they are clear enough. We do have some sublineage A, especially in Nigeria and in Southeast Asia region of WHO. So some of the differences that we have observed in this outbreak might also be due to the different distribution of these genomic of the different genotypes of monkeypox virus observed. Both clades, they have been impartially characterized in terms of epidemiology, clinical manifestation, and severity, but a lot of work needs to be further done to better understand the differences observed. What I wanted to highlight is that, of course, the big difference from the previous outbreak and the current one is the geographical spread, where these cases are, and what are the healthcare conditions. So some of the cases that have shown less severe disease in the Americas, in Europe, might simply be because the healthcare access, it's better in these settings than what previously observed in the African setting. I think I'm open to question afterwards. I will now hand over to Rosamund. I can continue presenting. Rosamund, over to you. Thank you.
Thank you very much, Anna. We have just 2 slides to wrap up this particular section. And so as you've heard, the Mpox outbreak was declared a public health emergency of international concern in July of 2022. That was the 2nd meeting, and we've just recently had the 4th meeting of the IHR Emergency Committee in February. So while the committee did commend WHO and all countries for their rapid and effective response to the outbreak, in many instances, the status of the public health emergency of international concern was deemed by the Director General to still be the case and maintained as such because of some of the concerns expressed by the Emergency Committee. These included the fact that whereas virtually all countries have shown a downturn in the number of cases reported on a weekly basis, in fact, in Central America, cases were rising. And so that region of the world had began the outbreak later than other regions. The outbreak kind of moved from Europe to North America, South America, and now Central America, as well as other countries early on. And so it was not at all clear that the Central American countries had yet managed to curb the outbreak that they were experiencing. This was one concern that was expressed. The second concern expressed is that, of course, Mpox is a zoonotic disease in the African region, but also now in the Eastern Mediterranean region of WHO. Sudan is a country in our EMRO region. However, Sudan is on the African continent and also declared outbreaks of clade 1 Mpox for the first time ever. And so there seems to be not only a geographic expansion of clade 2 monkeypox virus, but also of clade 1, which was certainly also new. And the fact that countries in Africa had not yet really accessed countermeasures such as vaccines and treatments, as had many other countries been able to do. Another point was the hard to reach and marginalized populations, even in richer countries. So whereas initially the outbreak affected primarily more affluent men who were able to travel, and now it's reaching more marginalized populations, including, for example, people who are marginalized in the sense of being on the street sometimes. Other groups, Black and brown men, are harder to reach because they feel more stigmatized in some instances, and have more difficulty gaining access to diagnostics and vaccines. And of course, in the African region, we remain with our hard to reach populations in rural areas who don't have access to diagnostics and countermeasures either. So the Emergency Committee still expressed these major ongoing concerns and asked WHO and countries through what we call temporary recommendations to continue to work on this response to make sure that this initial phase of the response, we're still less than 1 year, really make maximum efforts to control the outbreak, to continue engagement with regions and countries and other partners. Sorry, that says the report is under review by the Executive Director and Director General. In fact, the Director General reviewed it and declared that the emergency continued. Next slide, please. Thanks, Anna. And so during the outbreak, during the Emergency Committee, as well as through the temporary recommendations issued by the Director General, WHO is now supporting this strategic approach to managing the outbreak going forward, and that includes maintaining surveillance. It is very tempting when the number of cases goes down dramatically to stop surveillance or to reduce the frequency of reporting. But in order for us to, in a timely manner, detect new outbreaks, new importations, new community transmission related to, for example, events that are occurring around the world right now, Carnival, World Pride in different regions of the world, maintaining surveillance remains critically important for us to fully understand what has happened in this outbreak and to detect new cases. Furthermore, we've now understood that HIV in and of itself is not a risk factor for a severe disease, but untreated HIV, uncontrolled HIV, or undiagnosed HIV infection do represent risk factors for severe disease and death. There has been a lot of research into this now. Our data from WHO shows that, and data from other researchers presenting their clinical findings is very, very clear that if your HIV is not adequately controlled or treated, you have a very low CD4 count, then you may be at risk of very severe Mpox infection, including disseminated rash, rash affecting the eyes, the multi-organ disease, and so on. So what we're now also strongly supporting and recommending is that Mpox surveillance, prevention, control, and care be integrated into other programs wherever it is most appropriate in the local context. That could be primary health care, it could be sexual health services, and it could be, of course, HIV and STI routine care and prevention services. It is, of course, critically essential to continue to strengthen capacity in affected regions, notably in Africa, as well as other regions that are having more difficulty curbing their outbreak, and to continue to implement a very broad research agenda to address the many questions that remain unanswered in this outbreak. Work towards enhancing access to diagnostics, vaccines, and therapeutics remains absolutely critical. What the Emergency Committee actually requested is that countries develop elimination control plans for their outbreak according to their national context. Some regions and countries have declared that they wish to proceed to complete elimination of Mpox and rapid control of outbreaks. Of course, that's not possible in regions where the disease is enzootic, but control plans can also contribute to reducing morbidity and mortality from this emerging disease. Thanks. Back to you.
Thank you so much, both Dr. Hoxha and Dr. Lewis. That was a really interesting and thorough overview of the changes to the epidemiology, and particularly the differences for this outbreak versus previous ones, and also Dr. Lewis covering the kind of current situation technically and in countries, and how different countries are approaching the outbreak as it stands now. So that's really appreciated, and we have a few questions, but we'll come to that at the end of the presentations. So I'd like now to invite Dr. Ruben Mayorga Sagastume, the lead for HIV, TB, hepatitis, and STIs at WHO PAHO, to provide a regional perspective on lessons learned in the Americas. So Dr. Sagastume, over to you, the floor is yours.
Thank you very much, Supriya, and I would like to start presenting myself. I am also the incident manager for the IMST here in PAHO, as well as the lead for the HIV, TB, STI, and hepatitis unit in PAHO. Do I share my screen, or can you put the presentation up?
I think it would be great if you could share your screen.
Okay, so I think here it is.
Thank you.
Okay, so let me just hold on, please. Here we go. Okay. So yeah, developing on what Rosamund has previously said, what is the current situation and what are some of the challenges that we have? So mostly in most countries, operational planning was based on the SPRP, and plans were developed according to the pillars that were developed there. And the challenge now is how to integrate this into regular planning, as Rosamund was saying, probably into sexual health programs or into HIV and STI programs. Mpox virus PCR testing is available in all countries, and the challenges now is how to decentralize these PCR testing services, which has been done in some countries, but not in all to the degree that is probably necessary. Furthermore, surveillance guidance are developed, but monkeypox notification is underestimated, and we still need more integration into active and sentinel surveillance systems in countries of the region. We have had some contact tracing and case investigation in countries, especially using Go data in Chile and Paraguay, and we still need more strengthening and developing more contact tracing and investigations into cases as the cases become less frequent in the region. Still insufficient involvement of key population in preventive measures, and we still need more to be done between ministries of health and key population organizations to better coordinate and effectively respond to Mpox, including those in the most vulnerable context, as was mentioned by Rosamund recently. Also, early integration of all components of Mpox into the National AIDS Program, as done in Peru, did help successfully carry on surveillance and the response with a lot of community engagement. But this has not been the case in most countries, so we still need to integrate it into the AIDS programs, probably in the region. Vaccination plans have been developed in a few countries, but we have very limited supplies and lack of prioritization for the procurement of these vaccines by some ministries of health, in some cases due to the high price of these vaccines. And clinical management using Career-Mat and the adoption of a mirror protocol is presently in some countries, but the very limited supplies and the still very limited evidence about efficacy is a problem. So the way forward to keep Mpox in the radar, lobby with health authorities and civil society to maintain interest in Mpox beyond the fake. And I mentioned here health authorities and civil society, as has been seen in other cases, such as in HIV. Civil society demand creation is very important in order to maintain some services functioning. As mentioned before, integrating Mpox surveillance into STI surveillance, including Sentinel, and into the responses to HIV and STIs, and probably as part of genital ulcer management. And also, since we are proceeding now to having integrated care for key populations, also introducing Mpox clinical management into the HIV and STI clinical management of these populations, MSM, sex workers, trans women. Further engaging organized MSM and organizations of people living with HIV and other civil society organizations for risk communications, as these communications need to be in language that is understood by communities, and as also the ones that are mostly marginalized, as Rosamund was stating recently. Furthermore, risk communication to properly address stigma, discrimination, and counter infodemia. And of course, ensure sustainable supplies of vaccines, diagnostic, and therapeutics for countries that are still reporting cases, and some of those that are underreporting also. We have also spoken at PAHO about including Mpox as part of the PAHO's disease elimination initiative, and there are initial good thoughts about doing this. I spoke with the director recently, and he was favorable about including this into the disease elimination initiative. And finally, participating in research regarding new testing technologies, immunization, and therapeutics. I think that was it. Thank you very much, and I remain available for discussions and questions.
Okay, thank you so much, Dr. Ruben. That was a really interesting regional perspective on what has been done, what is still being done, and what still needs to be done, and current issues and initiatives from the PAHO WHO region, and really building on the previous presentations as well. So thank you so much for that, and we'll come to the questions shortly. But I'd now like to invite Dr. Supriya Bezbaruah, the team lead for WHO's EPI-WIN Science and Knowledge Translation, to discuss changing public and healthcare worker perspectives on the monkeypox outbreak, or Mpox outbreak, apologies. So Dr. Bezbaruah, the floor is yours.
Thank you very much, Priya. As you've heard from my colleagues about how the epidemiology of Mpox has changed, and my colleague Ruben has just mentioned also about infodemics being a challenge. Well, we know that in any public health emergency, there's a lot of, it's also a human emergency. People are anxious, people are worried, people are concerned, people want information on what to do and what not to do. They want to understand the science. So in WHO, we set up a taxonomy to listen to people's concerns, and we've had regular infodemic insights since May 2022 to understand what the public needs are, concerns are, as well as healthcare workers, and express and try and address them over time. We also see that how it's changed over time. We've also been monitoring it for 3 different languages, Spanish, French, and English, and across geographies across the world. We've addressed it mainly through community engagement, through my colleagues at the HIV department, been working with various relevant communities, as well as the EPI-WIN communities, the faith community, health in the world of work, through employers. We, of course, reach out to everyone through EPI-WIN webinars, through media engagement, which Rosamund has been very actively engaging with the media, and other risk communication engagement. But the basis of this is our listening and infodemic insights. So let me take you to right at the beginning of this outbreak, this emergency. As you can see, we also had the COVID pandemic going on, but the orange shows that there was a huge interest in monkeypox as well on digital media. This was in the early outbreak in the first 3 months from May. As you can see, initially, if you look at the orange peaks right at the beginning, digital media thought that this was a side effect of COVID-19 vaccinations. Then there were questions about also what this means and whether people need to be vaccinated, and also how the smallpox vaccine works and whether that would be effective against monkeypox. Then the interest dropped a bit till we come to July, and on 26 July, there were concerns about Mpox being an STI exclusively in the MSM community, leading to stigma and discrimination, which was quite rampant at that time. There were also posts at the same time, though, from the medical community, which warned about stigma and discrimination, particularly in healthcare settings, emphasizing that this would lead to worse treatment outcomes, and healthcare workers should be aware of that. After the first few months, the focus was more on South America and on Africa. And as you can see, this continues to be quite a lot of social digital engagement with Mpox in both South America and various countries in Africa. The key issues in South America are on the distribution of the Mpox vaccine, and there's a lot of social media chatter there in Colombia. There were also expressions of frustration about Mpox cases in Mexico. On the other hand, in Africa, in many countries, they're still questioning the existence of Mpox, which was an issue at the beginning of the outbreak as well. But in other countries, there's been a strong campaign for promoting public health and social measures with the hashtag Take Responsibility. This is particularly in Nigeria and Ethiopia. But across all those countries, the most common topics of concern are at-risk women and Mpox, particularly transgender and cis women, persistent stigmatization of the LGBTQ+ community, and polarized opinions on Mpox vaccines access and who should be vaccinated. Healthcare workers were particularly concerned and expressed their opinions. Healthcare workers are also important because how they see this outbreak makes a difference in the clinical settings. So this is this shows digital media that mentions healthcare workers, but could be also from the public. And it starts with July when the public, it was WHO declared Mpox a public health emergency of international concern. As you can see, there was tremendous interest initially, but then by September, interest has declined considerably. But initially there were calls, healthcare workers were concerned, there were calls for public health protocols, as well as some clinicians who said that this is considered a sexually transmitted virus. Then there were calls for the vaccine to be rolled out to healthcare workers, and also about the stigma issue coming up now, with calls for the LGBTQ+ community to be disassociated from Mpox exclusively. over August, the topics that were focused on were different ways of transmission, including airborne. And the debate then spread to Mpox in schools, as well as the simultaneous diagnosis of Mpox, HIV, and COVID-19. On the 31st of August, the first Mpox death in USA garnered a lot of interest, but towards the end in September, there was, very little interest till November, when Mpox name change happened, that garnered interest as well. This slide shows you about healthcare workers' posts and their knowledge. Initially, there were calls for wastewater testing for Mpox, and there were some health professionals who also said that this should not be regarded as solely a sexually transmitted disease. Later on, there were the demographics most affected by Mpox being focused on, and it was considered mainly a disease for the LGBTQ+ community and MSM. That raised some concerns. But at the same time, healthcare workers also emphasized the need for accessing information from trusted medical experts. This was a call that they took out quite strongly. By August, stigma continued to be an issue, and there were concerns about false information and stigma directed towards the LGBTQ+ community. Misinformation was quite an issue at that time, and health professionals really spoke up against it. By the 17th of August, there were guidelines on Mpox for people living with HIV, and this was tweeted quite widely and put on digital media by health professionals. So the knowledge was there. Later on, there were more questions about training sessions for healthcare professionals, as well as more knowledge about the management, prevention, and care of Mpox, particularly in South America, Colombia in particular. And by September, there was more healthcare professionals' interest on clinical trials and of sharing information about Mpox and pregnancy. Healthcare workers continue to be important and continue to share information on Mpox in this issue. So I'd like to end by acknowledging my colleagues in the Epidemic Management Unit, Tina Pernat, Atsuyoshi Ishizumi, and Al-Hassan Pereira Ibrahim. It's their work really that you see that we get to understand every 2 weeks concerns in the public and in healthcare workers. Thank you. Over to you, Priya.
Thank you very much, Supriya, and for all the colleagues that worked really hard and illustrating the importance of listening in this outbreak and others, and also building on points Rosamund made about stigma and awareness in particular groups, and also Dr. Ruben emphasizing the role of civil society and public perceptions at large. Before we move to the Q&A, we have one more speaker, Dr. Peter Mahler, who is the incident management lead for the Mpox response at WHO, to discuss the way forward for the Mpox outbreak. So Dr. Mahler, you have the floor. Don't know, Dr. Mahler, if you can put your camera and sound on, please.
I hope you can hear me properly. Yeah, thanks. I believe much of the way forward will emerge after the discussion session and the Q&A, but perhaps at this moment I could comment broadly on the way forward in terms of the outbreak response. As you're all aware, and as my previous colleague has mentioned, that the EC did make recommendations, and the DG acted upon the same and sustained the fake status of the outbreak. What that means for us is that we maintain our state of vigilance and make every effort we can to sustain and strengthen all the elements of the response. But broadly speaking, in terms of the way forward, we are looking ahead already in terms of where are we going, especially beyond the outbreak. So we are critically looking at these issues, and in a couple of minutes, if I may highlight just a few. One of them, the EC already gave us some guidance, as in how do we help countries to plan both mid and long term. So one of the key issues in terms of way forward is coming up with tools that will enable member states, especially those addressing elimination and those who might have more complex scenarios that involve zoonotic aspect and may probably focus more on long-term prevention and control, will need to support them in terms of coming up with tools, planning tools that can facilitate those response or prevention and control strategies. Of course, broader issues remain, and our PAHO colleagues already highlighted those. How do we address the issue of access to therapeutics and vaccines given cost? How do we tackle the research gaps? The research agenda that remains a big area going forward. To date, we don't know the actual animal vector of this virus, even though over the years we've known for years that it's a zoonotic disease. So that remains a major research gap, and going forward, there's need for more research around that area. I could highlight more and more and more, but in the interest of time, I could just mention one. For example, when we talk of integration, in practice, how are we going to move forward? I'm glad that our PAHO colleagues already broke down some pieces there, how on the surveillance aspect, the STI clinic where Mpox cases are most likely to be identified as a comorbidity or as a primary morbidity for those seeking STI services. That could be a point of contact where the surveillance system could pick the cases. And then in terms of treatment, then there is the integration with the HIV treatment that could facilitate access to treatment. Even thinking broadly, if for example, the Global Fund facility takes on this huge cost associated with therapeutics. Just speculating, but going forward, there is a lot that we need to think about to prevent and control this outbreak, especially in endemic settings, and those countries that will be targeting elimination. The European region has pronounced itself to that, and as we've had, PAHO also is contemplating that. And then we also have to think carefully how we deal with endemic countries where zoonotic aspects remain problematic, like DRC and so on. So I'll stop there, and let's carry on with the Q&As for deeper scrutiny of these issues. Thank you so much.
Thank you so much, Dr. Mala, for discussing some aspects of the way forward, as it were, on the outbreak. And just to pick up the points you just mentioned about costs and therapeutics, thank you everybody who submitted questions. We had a number that tackled this area. So, for example, Iza Tussar asks if drugs and vaccines developed for smallpox can also treat and prevent monkeypox. How readily available are they particularly in LMICs? Low and middle income countries. And Dr. Khan also asked the same thing, so how to do a similar thing, how to deal with this in developing countries like India. And also Shuyan Zhao how many doses of drugs and vaccines developed for smallpox have been used for treatment and prevention of monkeypox in LMICs. So the panelists have already touched on this, and Dr. Mala, you went a bit deeper, but if anybody wanted to add, that seemed to be quite a theme in the questions asked. So particularly how smallpox treatments were repurposed for monkeypox, and what role of cost and availability that played in particularly in LMICs. So anybody in the panel that wants to
Sure, I can start, and perhaps Dr. Brian would like to add on. Initially, it's important to realize that there has been a program of research for several decades since the eradication of smallpox in 1980. As Sylvie already mentioned, that the work has continued to develop effective treatments, which did not exist at the time of when smallpox was still around, and safer vaccines, which did exist and of course contributed to massively to eradication of smallpox. But the vaccines had side effects, so it was no longer beneficial for us to continue to be using vaccine in the absence of the disease. And so the program was to make safer vaccine products. So this is what we had at the beginning of this global outbreak, were products of smallpox research. Now, these viruses, the vaccines, for example, are made from something called vaccinia virus, which is also an orthopox virus. Smallpox is due to variola virus, which is also an orthopox virus, and monkeypox virus is an orthopox virus. So basically, there is cross protection and cross effectiveness of these products across different orthopox viruses. So they're really not necessarily perfect for any. We cannot expect them to be perfect because they're not specifically designed for a particular orthopox virus, but they do offer quite good protection from what we are seeing so far. The challenge was that these had been developed in the lab in the absence of smallpox, and also largely in the absence of monkeypox or Mpox in the early days. So there really were no, there were clinical studies for safety and immunogenicity, but there were no phase 3 clinical studies to actually test their effectiveness in the context of an Mpox outbreak. So from a regulatory perspective, it was necessary to carry out those studies. So as WHO, what we did at the beginning of the outbreak was two things. One is, on the one hand, provide guidance on how these products could be used for countries where they were made available from their smallpox reserves. And at the same time, provide guidance on further research and development and how the products could be used in the context of studies, randomized control trials, and other recommended study designs, so that more could be learned during this outbreak. So there are a number of reasons why they haven't been as available in low middle income countries. First of all, they were new products. They were simply not available on the open market. They were in national reserves for a different kind of disease outbreak. That has shifted. Number two, the cost remains quite significant. Again, because they were not commercialized for broader use. Hopefully that will also still change in the future, and we have different products at different in different cost categories. There are several different vaccines now, for example. Number three, the companies that produce these products indicated that whichever country requested the product, they did receive them upon request. For different reasons, many countries have not requested the products even when they were made available. For example, in the Americas region, the revolving fund, Ruben will speak to that, has in fact made the vaccines available to countries, and they have not all chosen to accept the vaccines. So it's also a national choice whether to request these products or not. And a big discussion needs to be had on how they can be used, because in some countries in the new outbreak, it was very clear who the population at risk would be and who would benefit. Very quickly became very clear who would benefit even from preventive vaccination before exposure, not just post-exposure vaccination. In different contexts, where more women are affected, more children are affected, the modes of exposure are different. There may be zoonotic transmission in rural areas. There may be person-to-person transmission, or even sexual transmission between men and women. It's much harder to see who really is at risk and what are actually the modes of transmission. So countries in the African region, for example, are now beginning this work. They have determined that they wish to really discuss what would be the appropriate modes of transmission to try to avert through vaccination. And one of them, for example, is health workers. So health workers may be at risk clearly, and there may be others. But sometimes these conversations are difficult around sexual transmission, and we are supporting the countries on how to have these conversations and how to develop strategies and plans.
Thank you, Dr. Lewis. And you also actually answered another question about why mass vaccination wasn't part of the strategic directions from Nagwa Kamis. So thank you for that. I don't know if any other panelists would like to add to Dr. Lewis's answer, or we can move on. Okay, I think we move on then. And actually, we had a grouped number of other questions around stigma. So Michelle Quay, for example, asks, considering the existence of stigma during this current Mpox outbreak, I would be interested to hear about Dr. Sagastume's experience collaborating with PAHO member countries in tackling the issue of stigma with affected populations. It's also something Dr. Lewis mentioned in her presentation. And another question also was around stigma. So maybe Dr. Sagastume, you could start with the answer to this, and then everyone could jump in if they want to add anything else.
Certainly. And at the beginning of the outbreak, there was a lot of reluctance to work with the community in order to develop communication materials and interventions that would help survey and take care of people who were being affected by Mpox. It became very apparent really soon that by involving the community and developing materials that were understandable by the community was the best way forward. I can tell you about the experience in Peru, where at the beginning there was no mention of the communities affected, no mention of who would be most at risk, and also this could have had an effect on the prioritization of people who would be vaccinated, because if you don't know who is being affected, you cannot develop the communications materials that are pertinent and relevant for that population. So if you engage that population, treat it respectfully, and develop together communication materials, that's a way to combat stigma. Mentioning the population is also very important in a respectful way, because that will guarantee that when you prioritize immunization programs, you do prioritize the populations that have the most risk of being infected, and also of developing the most severe forms of disease, as has been mentioned by my colleagues before. So in Peru, for example, at the beginning of the immunization efforts, people living with HIV were the ones that were prioritized. And very soon after that, men who have sex with men in general were also prioritized as pre-exposure prophylaxis. I can say that some countries in the region have followed that same path, and the community does engage ministries of health and does collaborate with ministries of health for prevention, for treatment, for surveillance when it's engaged, and when they work together with the ministries of health. So that would be a general observation. I would say that if you ignore the population, if you don't mention it, if you don't characterize the people that are being affected by a disease, then you cannot develop prevention or communication or immunization when it's available. Over.
Okay. Thank you, Dr. Ruben. And we are actually at time, but given that we started a few minutes later, I'm just going to carry on for a few minutes. And if you can stay, that would be wonderful. So I don't know if any other panelists want to build on the answer just given about stigma and awareness, and maybe what has been learnt from this outbreak that we can take forward more generally.
Well, I would just support what Ruben has said, that this is absolutely central for the global response in all regions and all countries. Communication, engagement with affected populations has been central to the response. And I think what Ruben has told us is that by co-creating the messages, we land on messages that are acceptable and destigmatizing.
Wonderful. And I think also from Supriya's presentation, we also saw the ways that WHO is trying to listen to those communities and do that in a systematic way. But thank you, Dr. Lewis. I should also say thank you very much to our panelists who have been busy answering questions in the Q&A box. And there are a number of questions about whether Mpox could become a pandemic, or if it was possible that it would replace COVID as a global pandemic. But Anna Hoxha, Dr. Hoxha, has replied in the chat, in the Q&A, box about that. So Dr. Hoxha, I don't know if we could share that question, because I think that is maybe something that is unclear to those working outside this area. So whether Mpox has the possibility of something like COVID. At the moment, it seemed to be in certain populations, but you've written that it currently has a limited spread, but maybe you could speak a bit more to that before we close, because I think that's a common question people had, particularly at the start of the Mpox outbreak.
Yeah, I can further elaborate a little bit on that. It was a common fear. I think the fact that we came from 2-3 years of COVID also impacted a lot at the time. Given the nature of the infection, I think we need to specify that it is a different virus. Its route of transmission is different than what COVID was, so therefore we should not put it together. We know that there might be some respiratory transmission of monkeypox, of Mpox, but this is really limited compared to the transmission that occurs when you are in contact with the lesions. And this means you need to have a close physical contact with the infected person. This physical contact can also, of course, be sexual, because during the sexual practice, you are having close physical contact, and this will limit per se the chains of transmission. They will not spread so much as they did with COVID. Other differences, I think, would be around the fact of the pre-symptomatic transmission. We have seen with Mpox, there might be some pre-symptomatic transmission, but at this point, we don't believe that it could be as big as it was with COVID. Additionally, with COVID, we had virus evolution. It's an RNA virus. It evolved much faster. So we got people that got infected multiple times over a couple of years of period. While with Mpox, there have been some changes in the virus DNA. It's a DNA virus. It's more stable. It evolves less frequent. It has not transmitted so much as COVID to evolve faster. There have been some changes observed, but at this point, it has not led to a different strain that can reinfect cases to our knowledge. So I think due to all these characteristics of the virus, of the infection per se, we are not expecting currently a big pandemic, although we need to highlight again that most of the human population is susceptible to the virus. So if you are in contact with it, most likely if you have not received a vaccine, you will be infected. Nevertheless, the potential of spread is more limited, according to the information we have collected so far. Thank you.
Okay, thank you so much, Dr. Hoxha. That was a super clear answer, and also balancing in understanding the spread can be limited, but also that anyone can get this, and to be cautious and to put policies in place accordingly. So we're now up to our allotted hour together. So I'd really like to thank everyone that submitted their questions. I think we got to all the themes of the questions, even if we didn't reach the specific ones. And really thank you to the panelists as well for answering those questions in the Q&A, as well as in our discussion. I'd like to thank our panel more generally for giving their time and giving such wonderful presentations. Our interpreters who've worked so hard in this hour, everyone behind the scenes who's helped put this webinar together, including other members of the science translation team, Jan Fang and Lubika, and also Supriya, our team lead. And of course, finally, and not last but not least, all of you for joining and participating in the discussion. The next EPI-WIN webinar will be on the 1st of March on influenza, and details will be posted shortly on the EPI-WIN website. So please check there. We really look forward to seeing you again, and thank you very much. Bye.
Thank you. Bye.
Thank you.
Thank you. Bye-bye.
Goodbye. Bye-bye.